going to talk about a couple advocacy wins that we as a college or as a state have had. We're going to talk about food and drink in the emergency department. Start with something simple, but if you don't think it's important, you haven't worked enough shifts. We're going to talk about what we call merit badges in medicine, talk about procedural sedation, and then Megan has encouraged me to tell a personal story that I worked with Amanda on a number of years ago on House Bill 7 called the I'm Sorry Law in Ohio. All right, so not that many years ago, this would have been taboo, these pictures. These are fine real life examples. On the left, we have a resident eating what can only be considered an emergency medicine lunch, veggies, ranch, and Diet Coke, right? And then on your right, actually, an actual sandwich from the cafeteria. But only a few years ago, this would have been illegal. And if hospital administrators or, God forbid, any kind of regulatory agent had seen this, the hospital would have been cited because this was a violation of OSHA and Joint Commission rules about food and drink. And you say, well, what's the big deal? Well, there's concern about contamination and infection and, please don't put the urine and the stool samples where the ranch is, right? But it actually got to the point that we, as a college, said, we need to have a policy statement on food and drink for staff in the emergency department, right? And it sounds silly, but this was life-changing for us because now I can feel free. Of course, this was right when the pandemic started, by the way, if you note the date, April 2020. So that did cause some problems because you had to be masked and stuff like that. But what it says is that, okay, the staff may have limited access to proper breaks. Ask an emergency medicine resident like Dr. Ladd, what's a break? She don't know what a break is, right? She and I literally worked together today. And at some point, I think we ate, but maybe not some days. So it's important. And we got this passed, right? So ACEP lobbied, this was important to our members, and we went to the Joint Commission and we fought the fight. And now you can have food and drink at your workstation in the department. So you're welcome. All right. So that's a simple win, right? That's not what most people think about with advocacy, but you talk about making a difference in my shift or Dr. Ladd's shift or a medical student shift, or our nurses, right? It's not just for us, right? We advocated for everybody. So, all right, let's talk about something maybe a little bit more serious. So for those that are medical students, you may have taken an ACLS, which is Advanced Cardiac Life Support, or PALS, Pediatric Advanced Life Support. And then once you get into your emergency medicine residency, you take Advanced Trauma Life Support, and then you take neonatal resuscitation. And right, we call these the medical merit badges, right? You got to show up to the course. And then just like the Boy Scout that I used to be, I was never an Eagle Scout. I didn't make it that far. You get your merit badge. So the one I specifically want to talk about is trauma. Right. So we get traumas. This is in our old ED, right? This is not an uncommon picture in a trauma, penetrating trauma. Obviously got a chest tube, dumped a bunch of blood on the floor. And when you're a brand new emergency medicine intern or a surgery intern, you have to take a course called Advanced Trauma Life Support, right? And it was kind of a thing that if you worked at a trauma hospital that you had to stay current with your ATLS, even after you finished your residency and you passed your emergency medicine boards and you were board certified, right? And it's a one-day course and it costs over $1,000 for an attending. And I just don't want to give up a day off to go take a course that I don't need to do because I'm board certified and I know how to take care of trauma patients, okay? So a number of years ago, the California chapter wrote a council resolution, and I'm not going to talk about council today, but briefly, council is the parliamentary body of the college that passes and debates resolutions to guide college policy, right? So policy statements come from council resolutions. And they said, we want to look, as the California chapter, we want to look at Trauma Center Certification Task Force. And the spirit of this resolution fundamentally changed when the college got into it and actually started working with the American College of Surgeons, right? So that's the surgeons' professional organization that certifies and accredits trauma centers around the country. And they actually came up with this clarification document in 2016. I can't believe this is 7 years old. Thanks, COVID. And the bottom line is, if you are board certified in emergency medicine by the American Board of Medical Specialties, so that's ABEM, right? So my residency training, the American Osteopathic Association, if you go to a DO program, or if you're from Canada, the Royal College of Physicians and Surgeons from Canada, that's all you need, right? So I never have to take ATLS for the rest of my life, thank God, because I know how to take care of trauma patients, right? And that doesn't seem like a big deal, but that's a really big deal, okay? The only thing is you have to have taken it once, right? And we all take it when we're interns. It's like month 1 of residency, and that's it. And once you finish your residency, you pass boards, you're good. And so every year, usually about 1 year after graduation, we'll get an email or a phone call or a text from one of our former residents at St. B's like, hey, Dr. McCrea, can you send me the surgeon thing that I don't have to take ATLS anymore? And I send them the document that I just showed you. And they're like, oh, no, that's your society's like, no, that's what the surgeon said. We don't have to do this anymore. So ACEP also has clinical policy statements about just the other merit badges. They didn't call them that in the policy. They called them short courses. AAM, I know this is an ACEP talk, but AAM has similar policy statements as well. And actually, this got to the point a number of years ago, it's actually happened right before COVID, that the Coalition to Oppose Medical Merit Badges, what we call the COME, was put together. And they said there is no rational justification to require medical merit badges for board-certified emergency physicians who maintain their board certification, right? Our committed professional organizations provide the best opportunities for continuous professional development, and medical merit badges dismiss the quality of those educational efforts. What does that mean? Right? A 3-year emergency medicine residency, becoming board certified and doing your maintenance of certification is way more detailed and comprehensive than a 4-hour online every 2-year renewal course, right? That's the point. And this was actually signed at the time by all of the presidents of all the emergency medicine organizations. And I can tell you it's not very often in EM that all of these organizations get together and agree on things. So real life example, I just recently got re-credentialed at one of our sister hospitals out in the community. And they said, Dr. McCrea, you need to send in your stuff. And I was like, no, I'm not going to. Well, you have to take the course. I don't want to. And I'm actually an instructor, which is the irony, as Megan knows. I was like, no, I'm not current, and I'm not going to take it. And here's the reason why. And they said, okay, because, they needed me to work there. But without that backing from our professional organizations, I wouldn't have been able to do that. And I, again, would have had to give up days off and pay money to take a course that isn't going to teach me anything and actually dumbs things down compared to how I actually practice. So the last big one I want to talk about is sedation. So I would say more days than not in our emergency department, if not every day, there is a procedural sedation being done for something. Okay, whether it's a pediatric laceration repair, a pediatric abscess drainage, or most commonly for an orthopedic procedure like a shoulder reduction or fracture reduction dislocation, or splinting, or just, gosh, I don't know, we got to get this person through CAT scan and we don't want to have to intubate them like we did when I trained. So we want to use medicines, right? And the big two that we care about are ketamine and propofol, right? So ketamine and Diprovan. But it wasn't that many years ago that one or both of these medicines were not allowed to be used by emergency physicians, because a lot of hospitals classify both of these as anesthetics, right? And I did an emergency medicine residency, not an anesthesia residency. And I've dealt with this at every community hospital I've ever worked at, where they say, you can't use this medicine. I'm like, well, but this is part of my practice. This is part of my training. I'm board certified in emergency medicine. Well, you can't use it here. Okay, what's the number for anesthesia so that I can call them to come in and do this? Oh, well, why don't we sit down and talk about that, right? So that's, again, advocating at your local level. And ACEP has a policy, procedural sedation in the emergency department. And this was actually just updated. And they said the NPO status has not been demonstrated to reduce risk of emesis or aspiration in the ED for procedural sedation, right? So what's that whole, right? You go into the operating room, you need to be NPO for at least 8 hours, preferably 12 hours, or anesthesia is going to cancel your case. So real life example, I was working at a community hospital and I had a kid with a nasty fracture dislocation that I tried once. I couldn't get it reduced. I didn't think I was going to be able to get it reduced. It just wouldn't stay. And I called ortho. He's like, yeah, no, I appreciate the call. Thanks for trying. I'll take the kid to the OR. But of course, it happened at recess after lunch. He had just eaten lunch. And anesthesia said, yeah, we'll do that at 8:30 tonight. So I told the orthopedic surgeon, like, I'll sedate him again if you come in and do it. He's like, wait, I can do this right now and not give up my entire evening? I'm like, yeah, no, I'll do it for you right now. Just come on in. And orthopedics was happy. I was happy. I got the patient out of the department. Most importantly, the parents were happy, and the kid didn't lay there in pain for 8 hours with a fracture dislocation that I couldn't reduce, right? And it's policies like this that actually make a difference in my day-to-day practice. This is the kind of stuff that ACEP does for you. And again, this is not a legislative thing. This isn't going to the Hill. This is working with our docs to make practice better for our patients and for us as physicians.